So my name's John Pauling. I'm a rheumatologist in Bath, and I have a clinical interest in systemic sclerosis, also an academic interest, a research interest in scleroderma, and I have a senior lecturer position at the university in Bath, and I'll talk about some of the work we've been doing in Bath, which has actually been funded by the Scleroderma Society, but now SRUK, and how the research we're doing is actually helping us as clinicians help patients, so that kind of positive feedback loop. And I've been asked to talk about the impact of systemic sclerosis, which is actually quite a difficult topic. It's a very broad topic, and it's a topic you can take off in different directions. But where I've tried to pitch this is, we know from focus group work with patients that one of the big things that contributes to the impact of the disease is uncertainty. What's going to happen a year from now? What's going to happen 5 years from now? Where am I going to be in 10 years? And we actually have a number of tools as clinicians that can help us predict the disease course. And I'll be talking about some of those clinical tools and some of those laboratory tools and how they actually help us as clinicians manage people with systemic sclerosis. So let's go on here. If I just need to work out how to move on to the next slide. Right. Oh dear. Oh yeah. Can you help me?
It doesn't look like it's actually on.
Is the battery? Oh, no.
No, it's there, but it doesn't look like it's actually functioning.
I don't mind doing it on the... You might need to...
We're struggling a bit here, mate.
I just can't move to the next slide.
Okay.
Yeah, there we go. So one of the things that makes scleroderma a fascinating and stimulating medical condition to be interested in is how varied it is, how heterogeneous it is. So I can do a scleroderma clinic and meet 10 or 11 patients, and none of those patients has been affected by scleroderma in the same way. And if you lined all the patients up, they'd all look slightly different, and you wouldn't be able to recognize they all have the same condition. And so the impact of systemic sclerosis is hugely dependent on how the condition has affected that person on an individual basis. So there are some disease manifestations that are common across the whole board, and hopefully we'll get to touch on some of those using questionnaire data that's been derived from a large study in Canada. But there are other disease manifestations that actually only occur in a very small percentage of patients. And as I've already mentioned, one of the things that's emerged from recent focus group work with patients is that one of the things that impacts on patients a lot is this uncertainty as to what the future holds. So I thought that'd be a good area to make the focus of this talk, to let you know which tools we use as clinicians to help us on that, in that regard. And as I say, I'll also be mentioning some of the research that SRUK are helping to fund, which is helping us develop this field. So we routinely send our patients copies of the clinic letters, and our clinical letters is a tool that we use as healthcare professionals to share information with other healthcare professionals. So they often get littered with medical jargon that can actually confuse and promote fear in patients. So I'll try and address some of these things that you'll read in letters to help you understand what we actually mean when we put these terms. So I think one of the scariest times for a patient is when their very first visit with a rheumatologist, where they get told you actually have a condition called systemic sclerosis and this is what it is. And a visit for a brand new patient, at the very least, we'll always have a discussion about the nature of these conditions, but they'll always go home with some educational material. I'm always conscious that during that initial meeting, it's a bit of a blur of what did he say, what did he mean by this? I can't remember what he actually said. So at least this material allows people to go home, have a cup of tea, read it in a less hurried fashion. But one of the things that provokes a lot of fear for myself as a healthcare clinician is I know that as soon as they've put that down, they'll open the internet and look at this. So this is the front page you get if you Google images systemic sclerosis. And this is a Pandora's box of fear and dread and worry. And one of the things that I'm going to try and press on you is the type of image that finds its way onto the internet, the patient's experiences, the case histories you'll read, are often the worst case scenarios. They're the worst of the worst. That's why they've been sufficiently interesting to find their way into medical journals, into medical presentations. Patients have uploaded them on patient blogs. And in fact, actually, as well as Googling images, one area which we know our patients use as a source of information, we heard this from Katrina when she said it was a Facebook group that got her interested in pursuing a stem cell transplant, is patient forums and blogs. But again, one thing I'd advise caution on is the types of experiences that find their way into patient forums and patient blogs are often very negative experiences surrounding the illness, either very severe manifestations or negative experiences with healthcare professionals. But actually, I quite like reading these because it just reminds us as clinicians the type of things that actually could generate a huge amount of fear for patients. And actually, it reminds us how scary it must be to be told they've got this rare condition they've never heard of. If you go to your GP and the GP says you've got high blood pressure, you can usually stroll out thinking, well, at least I know 10 other people who've got high blood pressure and they're all doing fine, Whereas being told you've got systemic sclerosis and then telling all your friends and family, I've got this condition, no one's ever heard of it, is pretty fear-provoking stuff. So the area I encourage patients to visit for good advice is the Scleroderma and Raynaud's UK website. So I say, look, read these booklets, but at the back, make sure you look at this. And we need to update the AR UK booklets now to make sure that, I always write, you're going to have to look for SRUK. But actually, if you type in SRUK and Scleroderma, you very quickly get onto this website. And one of the things that SRUK have done a huge amount on is putting educational material to make this the site to visit if you want to learn more about your condition. And here's another good piece of advice. So this is a quote from Benjamin Franklin, who was a writer, a scientist, and a politician. And he said, do not anticipate trouble or worry about what may never happen. And I think that's a very useful adage in scleroderma. He also followed it up with, keep in the sunlight, which is another very useful adage for people with systemic sclerosis. Stay warm and keep your peripheries nice and warm. But, oops. I'm sorry about the issues we've had with the IT today. But the adage of it might never happen is very true in systemic sclerosis. And in actual fact, there's good evidence to say it probably won't. And what's been blocked out here, which you can just about make out the wording of, is there's this 15% rule in systemic sclerosis. 15% or 1 in 6. And this is a large study that was done by the Canadian Scleroderma Research Group. And what they found was that it was only the most severe organ manifestations of systemic sclerosis generally only occur in 1 in 6 patients, which means that 6 out of 7 patients will not develop any of those severe organ manifestations. So pulmonary arterial hypertension, we've heard a little bit about today as well. The blood vessels in the lungs develop Raynaud-like problems, which can put pressure on the heart. The scleroderma renal crisis is where the kidney can become damaged in scleroderma. Severe interstitial lung disease, which can actually severely affect function and shorten life, again, will only affect about 15% of patients. And another thing that we certainly see as clinicians is it's unusual for a patient to have more than one severe organ manifestation of systemic sclerosis. So if you are unlucky enough to have recurrent finger ulcers, it might be that that's telling us that you have a particular type of scleroderma in which you'll never, ever develop a renal crisis. So knowing this means that when you go off and read things in the literature or meet other patients with scleroderma at meetings like this, if they say, oh, well, I've had an awful year because this happened, it might be that you actually will never have that because your big problem is this. And thankfully, there are tools available to us as clinicians that can help us predict the disease course. And I'll talk about how we use those tools and how I use those tools in the clinic to actually say to patients, look, you don't need to worry about this. If there's one area we need to be a bit worried about for the potential future, it might be this. We'll talk about those. So again, this was a busy slide. There was a lot of data, but this was a nice study. Again, it came out of the Canadian Scleroderma Research Group. They asked 1,000 patients to rank the most severe symptoms they have in systemic sclerosis. And this is an interesting study because it does take lots of patients with lots of different types of systemic sclerosis and ask what symptoms bother you most. And top of the list, and you could probably guess this, that there was a groan in the audience that suggested they would have predicted it too. Top of the list was fatigue. It was the one which across the board seemed to be the commonest symptom. Number 2 in the list was Raynaud's phenomenon. And other ones that made the top 10 were symptoms like difficulty using my hands, skin tightening on my fingers. These are symptoms that we'll often see across the board in scleroderma. None of these are those severe organ manifestations that would shorten your life, but they obviously cause an awful lot of burden for patients and have a major impact in quality of life. But the symptoms that are commonest across scleroderma, I'd say, they're the non-life-threatening manifestations. The really severe life-threatening manifestations are the ones that conform to that 15% rule. It's more likely not to happen than happen. And as I say, it's this uncertainty about what the future holds that's emerged from focus groups as being a major fear and burden of disease that troubles patients on a daily basis. So what tools do we have? Well, one tool we have is the antibodies that patients carry, and we're going to spend a lot of time talking about those. And the other is the extent of skin involvement. One of the things that SRUK asked me to talk about is what are the differences between limited and diffuse systemic sclerosis. So when we use the term limited cutaneous systemic sclerosis, generally the skin changes are limited to below the elbows and below the knees and the face. So the actual body and the upper arms and the upper legs are left alone. Whereas in diffuse cutaneous systemic sclerosis, the skin changes can be much more widespread. They're not necessarily always very widespread, but if there's any involvement of the upper arm, we would generally use the term diffuse involvement, even if there wasn't any involvement on the tummy. And in the very broadest of terms, if you have diffuse cutaneous systemic sclerosis, where you have a lot of scar tissue formation in the skin, you are likely to have a disease course that generally involves more in the way of problems related to scar tissue formation. So we also worry about fibrosis or scar tissue forming within the lungs or the heart or the gastrointestinal tract. But remember that 15% rule. If you have diffuse cutaneous, it's the chance of you having severe gut involvement or severe lung fibrosis is still only about 1 in 6. We also worry more about the kidneys in patients with diffuse cutaneous systemic sclerosis. Whereas if you have limited cutaneous systemic sclerosis, as the name suggests, scar tissue formation is less of a problem, and the vascular aspects of the disease are generally more problematic. Severe Raynaud symptoms, problems with ulcers on the fingers and toes, and there's pulmonary arterial hypertension. And actually, Ariane Herrick in her breakout group earlier was talking about some of these vascular effects, calcinosis and telangiectasia. But actually, those more fibrotic complications are less common in this group of patients. So just by looking at which parts of the skin are affected can give us an initial clue as to what the likely disease course is going to be. And for many years, this was as good as we had. But now we also use antibody testing. And antibodies are these small proteins that circulate in our bloodstream, which are designed to help identify viruses and bacteria. And they cling to the side of those viruses. They're these little Y-shaped proteins that you can see on the image at the top right. And when they cling onto the edge of a bacteria or virus, that acts as an alarm signal to other immune cells to come and clear those pathogens out of the system before infection develops. And we've got billions and billions of these antibodies swimming around our system, constantly on the lookout for little proteins or cells that shouldn't be in our circulation. But one of the things that occurs in autoimmunity is the development of these antibodies that are actually targeting our own body's cellular constituents and cells. So we shouldn't develop antibodies that are targeting our own tissue, because then we can create an immune response against ourselves. That's what happens in autoimmunity. And that is at the heart of conditions like systemic sclerosis. But where this helps us as clinicians is we're able to actually look for specific antibodies targeting specific proteins. And they're useful in both the diagnosis, because there's about 7 of these Scleroderma-specific antibodies that we can test for. But also, you're highly likely to only have one of those antibodies. So patients will often, if they have anti-centromere, they won't have anti-topoisomerase, for example. You will only have one of these antibodies in your system. But the other reason they're helpful is they actually help predict the disease course. So we know that if you carry antibody A, this is likely to happen over the next 5, 10, 15 years. If you carry antibody B, it's likely to be this. And that's where I'm going to bring the focus of the talk. It's trying to address some of that uncertainty that can occur. So this is a schematic that we use to teach other healthcare clinicians how these antibodies are associated with different disease manifestations in scleroderma. And one of the things that's interesting about the antibody carriage is, since antibodies were first looked for in scleroderma in the 60s, when they didn't have very useful tools for looking for the antibodies, they only found them in about 60% of patients. But as we've developed better tools and better laboratory techniques for looking for these antibodies, we're now finding them in about 95% of cases. But that does beg the question, what about the other 5%? And that's an area I'll come to later on. So anti-centromere antibodies occur in about 1/3 of patients with systemic sclerosis, 1 in 3. And they're generally associated with limited cutaneous systemic sclerosis. And if there were a problem that we'd worry most about, it would be Raynaud's phenomenon and ulcers. Finger ulcers occur in about 6 out of 10 people with anti-centromere antibodies. But severe recurrent ulcers every winter only affects 15%, 1 in 6. So it conforms to that 15% rule. So a number of patients with anti-centromere, they might have one antibody early on in their disease course, and it might be another 10 years before they develop another one. So I'll say the presence of ulcers isn't infrequent, but severe ulcers every winter, predictably, that affects a much smaller percentage. And as Professor Herrick was saying earlier, calcinosis can affect 5 out of 10, about half of patients with this antibody. But a lot of patients might have 1 or 2 small little lumps of calcinosis that don't cause them any bother at all. Whereas the image she showed earlier of somebody with really lumpy calcinosis in their hands, that occurs in a much smaller percentage. And again, severe calcinosis causing problems would affect about 1 in 7, 1 in 6 patients, around 15%. But if you've been diagnosed with anti-centromere positive limited cutaneous systemic sclerosis, and you go into Google and start reading about people developing severe lung fibrosis or renal crises affecting their kidneys, that will never happen to you. So this is an example of where knowing which antibody, you can actually immediately say to patients, you don't need to worry about this or this. We need to, if we are going to be concerned about the future, this is the area we need to be concerned about. Now, I'm going to add as a caveat here that none of these rules are hard and fast. And I know there have been cases of patients with anti-centromere developing a renal crisis, but they're the types of cases that really kind of astonish us as healthcare clinicians interested in scleroderma. We're like, wow, that's great. Amazing that you've seen that, because I've never seen that. And for example, I've never seen anyone develop a renal crisis with anti-centromere, but I know it has been described. The area we'd probably worry most about with this particular group of antibodies, and it fits in with this vascular theme, is this pulmonary arterial hypertension. And because now with this antibody we're dealing with a smaller group of patients, the chance is actually higher than 15%. It's about 20%, about 1 in 5 chance of you developing pulmonary arterial hypertension at some point in the disease course. But let's not forget that that means that there's a 4 in 5 chance that that will never, ever happen. So, knowing the percentages means that we can give patients informed judgments as to what might happen in the future. It also means that we can keep a very close eye. We have a number of effective tools to help monitor for the emergence of pulmonary arterial hypertension. So in somebody with anti-centromere, I would be doing lung function tests and echocardiograms and blood tests looking for these proteins that can suggest heart strain religiously on a yearly basis. And I map out those results and I look to see how trends are changing. I educate patients, look, this is what's happening to this, to help them understand what's happening. And if there's any suggestion of a downward trajectory, then we can get in early, look for it, and treat if needs be. And also, by knowing this, we're able to, we know that if you manage people with their Raynaud's aggressively with anti-Centromere, you might actually be able to reduce that future risk of pulmonary arterial hypertension by about half. So we are now finding that with more aggressive use of blood vessel opening treatments, including treatments that 10 years ago cost £6,000 a year and now cost about £200 a year, we're able to use lots of drugs now for Raynaud's that we previously couldn't. And I think that's going to have a massive effect on the number of patients who actually go on to develop these more life-threatening, worrying features of systemic sclerosis. So I'm hoping that'll be the big stride forward over the next 5 years. We'll start to see that emerge in registry data. So this is another antibody that we'll sometimes see, anti-topoisomerase or anti-SCL70. This occurs in about 1 in 5 people with scleroderma. And actually, this is one antibody that can be associated with limited disease or diffuse. And sometimes patients who've been limited for many years will suddenly develop more diffuse skin changes at a later stage. Raynaud's can be a problem, and about 6 out of 10 people will develop finger ulcers at some point in the disease course. But again, that can be sporadic. It could be just a single ulcer. And the numbers who get recurrent ulcers every winter, a bit like anti-Centromere, is much lower, about 1 in 6, about 15%. An area we do worry about with this anti-topoisomerase is the development of scar tissue formation on the lungs. And that affects about 7 in 10 patients, which sounds worrying on the face of it, but actually a much smaller percentage develop severe lung fibrosis. It's nearer the 15% range. So we have a number of patients who have anti-topoisomerase 1 antibodies who do have a degree of scar tissue formation on the lungs, but they're not really aware of it. They're managing perfectly well, they're working, they participate in sport, but we know it's there and we keep a very close eye on it. And we're looking to see something change that suggests it's progressing so that we can intervene quicker. But again, knowing which antibody these patients carry allows us to look and undertake surveillance for these types of complications more rigorously. And the final antibody that I'll describe is anti-RNA polymerase 3. And this affects about 1 in 6 patients with scleroderma. And often the scleroderma is rapidly progressive, so they'll develop Raynaud's in the January, some itching of their skin in February. By March, they've got widespread skin thickening. And the area we worry most about with this group of patients is this scleroderma renal crisis, which affects about 1 in 3 patients with this particular antibody. Actually, one silver lining if you've had a renal crisis is if you've had a renal crisis with this particular antibody, your life expectancy is better than other people with scleroderma. Because if that happens, that will almost certainly be the worst thing that will ever happen to you. So if you get through that, then actually your prognosis is very good. But we'd much prefer it didn't happen in the first place. And this is one area where I'll encourage patients to actually keep an eye on their blood pressure at home and actually get in contact with me if their blood pressure starts to rise. You know, if it goes up to 150 one afternoon and they've had a little sit down and calm down, it's dropped back down, that's fine. But if over the course of a few days it just keeps on going up, I want them to get in contact with me so we can nip it in the bud. We do have effective treatments for these types of problems. But I don't want all of my patients with systemic sclerosis to be checking their blood pressure 2 or 3 times a week, because patients of anti-Centromere never develop renal crises, or almost never develop. I've never seen it. So I wouldn't want them to be burdened with checking their blood pressure religiously for a problem that almost certainly will never happen. So this is how we use these antibodies in clinical practice. And the 3 antibodies I've described have actually now been included in the classification criteria for systemic sclerosis, such as their importance in terms of diagnosis. And so I'll just give you an example of how these tests help us in clinical practice. So this is a lady who's kind of given me permission to present her case at meetings such as this. She developed Raynaud's in her 80s, which is very unusual. That's a red flag. That needs investigation. And then she developed a finger ulcer. Again, Raynaud's, primary Raynaud's shouldn't cause a finger ulcer. So just the history alone here makes me think, look, there might be something more going on here. And then the investigations we undertook, the microvascular imaging studies are the ones on the left, which showed delayed rewarming following a cold challenge, but also very abnormal looking blood vessels at the nail fold. And when we did autoantibody testing, we found these anti-Centromere antibodies. So armed with this knowledge, I was able to say to this lady with some confidence, no, you do have systemic sclerosis, even though you don't have any skin thickening at all. And this is what we need to do from now on. But what about those 5% of patients who are ANA negative, who don't appear to carry any of these proteins? A large study in the US, based in Texas, identified 208 patients from a group of 3,200 who are ANA negative. And this is quite an interesting group of patients because it might be telling us something unique about the disease. But we're also interested in this group because one of the things that we've been working on in Bath is the identification of new antibodies in systemic sclerosis. We identified this new antibody targeting a protein called EIF2B. And the target isn't important, but what was important was many of the patients who we identified it in the original 7 patients, had lung fibrosis, scar tissue formation on the lungs. And we were excited by this because we thought, okay, this might be another useful tool we have to help predict disease course. But we'd actually taken a lot of these samples from the Royal Brompton Hospital here in London, which specializes in managing scleroderma lung fibrosis. So we said, well, maybe they all had lung fibrosis because of the hospital we collected them from. So SRUK have funded some research in Bath where we took all those samples from America, and it was a completely unselected group and we looked to see if we could find this antibody in that group of patients. And we found the antibody in 9 patients, and then when we then mapped the presence of the antibody with the clinical details, we found significant lung fibrosis in 7 of those 9 patients. So this is another example of one of these antibodies occurring on its own, so not in conjunction with any of the other scleroderma antibodies, but also giving us a very clear steer as to what the disease associations were with that particular antibody. And it's an example of how the work of the SRUK supports us as researchers trying to develop new tools to assess and manage these conditions that then helps patients by us then putting these into clinical practice and then being able to say to patients in 5 years' time, oh, you have this particular antibody, we know that this is what we need to look out for. So to conclude, systemic sclerosis is a hugely varied disease, and you can't think or talk about the impact of systemic sclerosis without knowing more about the particular patient in front of you and how the disease is either affecting them currently or likely to affect them in the future. Patients seeking information about systemic sclerosis early in the course of the disease could be easily unduly worried. There's horror stories on the internet and patient forums, and potentially for things that will never happen to them. We have tests available to us as clinicians that can help us predict what the likely disease course is, and I'd encourage you all to become aware of which antibodies you carry and speak with your rheumatologist to say, well, which antibody do I carry? What does this mean for me? And the SRUK, as I mentioned, are supporting research in this field to help us as clinicians to help you as patients. So it's one of the reasons I'm passionate about medical research is it's a very positive feedback loop where we're all helping each other to move the field forward. And we've already, as I mentioned, seen great strides in this area. Yeah.